Hello, everyone, and thank you for joining us. Today, we have Cynthia Reddick, who is a home tube feeding expert, educator, and strategist who has worked in home care for 23 years. She is passionate about facilitating patients' successful transition on tube feeding from hospital to home. She works to promote positive clinical outcomes and believes a patient's positive relationship with their feeding tube impacts compliance and quality of life. She developed her passion for nutrition support interning at the City of Hope National Medical Center in Southern California. Most recently, she worked for Quorum/CVS Specialty Infusion Services as their national tube feeding manager. Today, she works as a consultant in the area of home tube feeding and enteral innovation. She enjoys presenting roundtables, clinical posters, webinars, and case studies in the area of home care tube feeding, and has been a guest speaker for the Ole Foundation, Case Management Society of America, National Home Infusion Association, Aspen, and the Academy of Nutrition and Dietetics on a variety of topics related to home tube feeding. And again, we want to thank the Dietitians and Nutrition Support Dietetic Practice Group of the Academy of Nutrition and Dietetics for providing the research grant to make this presentation possible. I'm going to hand it over to you, Cynthia.
Thank you, Stephanie, and thank you for having me join this very special group of clinicians. I'm really excited to be here and to share my experience and knowledge with you. And I also look forward to learning from you. So we are going to cover quite a bit of ground today. But first, here are my disclosures. All right, so buckle up here. So my goal is to finish in time for some lively Q&A, which I've been prepped that this is a lively and interactive group, so I'm counting on that. So just from a housekeeping perspective, please feel free to drop things into the chat if you have questions along the way so that you don't forget them. And I will do my best to keep an eye on that and also try to weave in some of those answers. But if I don't get to them, then I'll get to them at the end. But in the meantime, I want to talk about different innovations in enteral formula, and I'm going to walk you through my thought process and the way that I categorize them, because there's been innovation in that space. And in that space, there's been more inclusion of whole food formulas, commercially prepared blends, as well as home blends in this setting, as well as in this population. So we'll talk about that a little bit, including methods of administration. So different home care friendly, I'll call them home care friendly hacks or home care friendly alternatives to the different methods of administration for bolus and gravity in particular is what I'm going to focus on. And then different aspects of enteral nutrition tolerance is what we'll wrap up with, and ways that we can make adjustments to feeding regimens, to formula, but then also within tolerance, I also consider tube tolerance part of that assessment as well. So we'll talk about some different complications that I've seen out there and the ways that we can address those things so that patients have a good experience with their feeding tube. We know that impacts compliance. But before I start that, so I want to congratulate you for being here. Hopefully by the end of this, I will baptize you into my tribe of dietitians that I invite to get a little more hands-on with feeding tubes in particular. So at the end of the day, but I want to share a little story with you. This is something that I learned from a dietitian that I worked with many years ago when I was still a tech. I hadn't even gotten into my internship yet. I was diet teching in this tiny little hospital in Southern California. And the dietitian said something to me in passing one day. And she was, I think, giving me some words of wisdom. And because she knew about what this journey was ahead of me. And she said, get good at things that other people are afraid of and set yourself apart. And that's something that I've embraced and passed along. And I feel like tube feeding is one of those things. And then even deeper into tube feeding, getting familiar with all of the innovation that's out there and also specifically the devices themselves. So I invite you to get good at things that other people are afraid of and add a way to set yourself apart. So let's talk about the enteral formula categories that you're dealing with primarily with this population. So this is how I organize them. So work with me here. So in the first column on the left, there are these brief descriptions, right? Blenderized, standard, hydrolyzed, and disease specific. But below that are these HCPCS codes. And maybe if you're dealing with making arrangements for home tube feeding, you're familiar with these. But in home care, when we're billing for formula, these are the different codes that we use to do that with. It's a communication mechanism with insurance companies. We don't bill formula names. We bill these HCPCS codes, B4149, B4150, et cetera. So that's what that is on the left column. And then there's some basic descriptions. So there's a blenderized category and what the typical calorie ranges look like. There's standard formulations. So this B4150 and 52 category, that one's in green because it's a really good category for the ALS population, especially if they're Medicare, because those two codes don't require any special justification. And then your hydrolyzed B4153 category, maybe you will use this with your ALS population, maybe you won't, but that's the peptides basically, and then your disease specific, so your diabetic, renal, and pulmonary. And what's happened across all four of these buckets is we've had innovation where we have organic and plant-based options available in each one of these categories. So on this slide, what I want to do is tease out a little bit of the options, if you will. So we've got our codes on the left, your B4149, 50, 53, and 54s. And then in the middle column are food-based formulas. So formulas that actually have whole food ingredients in them and again, these are commercially prepared formulas, right? So your B4149 category has its own code it was the original code for formulas that had whole food in them or whole food ingredients in them. But what's happened is we have had innovation, get my little laser pointer out here. We have had innovation in these other codes where we now have food-based ingredients available in peptide category, the B4153. We also have whole food ingredients available in the diabetic category. And this one's actually an oldie but goodie. We've had this formula has been on the market a really long time, but there's a diabetic formula that's had whole food ingredients in there for a long time. But then when we go over to this column, so here's our plant-based formulations. These don't have whole food ingredients, and so they cross a different section of formula categories. So your B4150 does not have a whole food option, right? By definition, the whole food option falls into this B4149 or blended formula category. But this B4150 or standard formulas there's now a plant-based option in organic and non-organic options available. The same is true for your B4153 or your peptides. So your peptides have either whole food ingredient options out there or just a plant-based option without whole food ingredients. And then the same is true in this B4154 category, or the diabetic formula in particular has a whole food option, but then there's also a plant-based option. So this is the way I organize it in my mind, because I have found that, and I'm trying to convey this to you in a way that makes sense, because I found that clinicians across the board, whether they're dietitians, physicians, nurses, there's confusion about whether it's organic or food-based, and they get them kind of mixed up and mixed together because it's not this clean, simple categories of formula anymore. There's this organic and plant-based and whole food options have sort of spilled into all these different categories. So moving on. This is my attempt to pass along to you things I've learned along the way in home care, ways to make the home care experience more, I guess, home care friendly. I don't know. That's the language I use to make supply management and formula management, and the administration of formula, home care friendly for patients. So what I put together here for you is a comparison. So what does a 2,500 calorie regimen look like at home when it's a 1 cal, or when it's a 1.5 cal, or when it's a 2 cal option? And it translates to cartons per day, cartons per month that are shipped to the home, and what that looks like in the cases that get shipped out to that patient. So if you've got a patient, many of the patients that we're dealing with this in this population, we're trying to either maintain their weight, or we're first and foremost trying to prevent them from losing any weight, right? And so either maintain weight, and in some cases try to help them gain a little bit of weight back that they had lost along their journey to diagnosis. So 1 cal may not be the best option. I think we all know that, and this is why it translates. The most popular option in the home care space is this 1.5 calorie per ml option. You can see there's a big difference. It cuts the volume down from 12 cases a month to 8 cases a month. And then if you go up to a 2 cal, it actually cuts that in half from 12 cases to 6 cases a month. The only issue here is that, and we'll talk about this a little bit later in the presentation, is our 2 cal options right now in the US, they don't have any fiber containing options. So that's something that you would have to supplement for patients. And we know that that is important. But this is my visual representation of why we want to move towards a 1.5 or a 2 cal for this population. And many others as well, outside of the ALS population. So let's talk about blenderized. I've touched on this a little bit. We know that in a lot of the research, they're showing improved tolerance for patients on tube feeding. A lot of the research originally was really focused on the pediatric population. There's a decrease in reflux, retching, vomiting in this population. It's always been a go-to for mine. When I started in home care, looking at a blended option was something that I would look at for patients with diarrhea or constipation. And avoiding food allergies is a more recent reason for patients to use what we call BTF. Sometimes there's patient preference. It does diversify gut microbiota, and there's evidence coming about that. And then there's this psychosocial and quality of life aspect to it. Sometimes, we encounter patients that have this idea that it's just more in alignment with their belief system about nutrition to include formulas that maybe don't have so many what they would perceive as like artificial ingredients. But we have things to consider. So if we're using blenderized tube feeding, then we have to look at across the board at the different things that could impact their ability to do that. So enteral access, we need good French size of the feeding tube, usually recommended 12 to 14 French or larger. Gastric access is generally preferred, though I have seen patients with J tubes succeed on a blended option. And a mature stoma is recommended before initiating that. From a supply perspective, if they're using like a recipe at home and making their own blends at home, obviously having the right equipment for that, storage prep, recipes, these are necessary. Administration methods that are recommended for blended formulations are either bolus or gravity or bully bag, which I'll introduce you to if you haven't seen that already. But I do know from my own research and studying this population that many of them do in fact use pumps. So that's a whole other presentation. But the administration method hacks I'm going to tap into a little bit later here in the presentation. And then again, if patients are strictly blenderizing at home, then having that clinical support is really key. Just making sure the blend meets their nutrition needs, having a dietitian involved in that, and having a clinician who has some expertise in complication management. And that's true regardless of what formula they're using, quite frankly. So this is just a resource for you to tuck in your pocket. This was published several years ago in the Oli Foundation's Lifeline letter. And this was something I helped with a variety of other practitioners. And there's recipes in there. There's a lot of helpful information in there. But the real takeaway that I wanted to pass along to you is that the use of whole food through a feeding tube does not have to be an all or nothing proposition. It can be a combination of commercial formula with a little bit of home blend or even store-bought prunes. That could be just a simple way of weaving in some whole food options, or using a commercially prepared blend with a home blend, or some patients, although it's a little bit harder and it's a bigger burden to do 100% whole blend, but it doesn't have to be that way. Patients can dip into it in small ways as well, and can meet psychosocial needs, but also meet some clinical needs for themselves. So I like sharing this study because it was designed, there's a couple things that I want to talk to you about here. So the study was designed to evaluate the incidence of clogs in feeding tubes with ALS patients that use BTF. And at the end of the day, this study, they showed no occlusions were found in their patient population. But the other reason that I wanted to share this study is that it gives a look for you in the literature at the incidence of BTF use in the ALS population. So this was a retrospective study. It's a Canadian study where they looked at the medical records of over 600 patients, ALS patients, in a Vancouver ALS clinic over the course of several years. And they identified 97 patients that were tube fed. So that was about 15% of their ALS population that they studied, of the charts that they reviewed. And so out of those 100 or so patients, 21% used blenderized tube feeding. But the interesting part was that 1/3 of that population, of that 100 patients, used BTF exclusively, but 2/3 used a combination. And I think that's what's really telling, and that's really consistent with my observation, is that in some way, shape, or form, our patients are doing this anyway, whether they're telling you about it or not. They are adding real food to their regimen in one form, or many of them, at least 2/3 of them are doing that in one form or another. And there are other studies that have supported that as well. But back to the tube clog results in this population, I think it's notable that they all received, everybody in this study received blenderized tube feeding through a gastrostomy tube, and that French size was anywhere between 14 and 24 French. So that gives you a little insight into why they were successful. And they were using a varied administration methods of flushing. So it wasn't like a standardized flushing regimen. So there was variables in their compliance and then in their flushing regimen. And I think the real takeaway is that despite the risk, or the perceived risk, of clogs, there were none to have been found in this study. So this is my gift to you. If you're not already aware of it, this is a resource and a tool that's available on the Nestle website. So there's 2 links here. This one right here brings you to the recipe builder if you need some resources to figure out how to assemble a blend for a patient that really wants to do this. There's a way for them to build a recipe at this website. And then the second link is actually a webinar that shows you how the recipe builder works. And it was developed and designed, and this content was delivered by Robin Cook, and she's out at CHOP in Philadelphia. Okay, but I want to tell you about John's story. So he's not an ALS patient, so that's my first disclosure, but he was one of those patients in my journey that taught me some things. And I have had so many of those. And when I am able to capture it and share it with you, I find it very meaningful, because his journey, he came to me with a tube complication. He had a leaky tube. He had a lot of reflux and phlegm, and he was just a very unhappy camper with his tube feeding. And as I was troubleshooting his feeding tube, he was sending me pictures, and he sent me this picture, and I was struck by how malnourished he looked, right? I already knew he was underweight. I knew that he was not taking in all of the nutrition that he was prescribed, and I was trying to help overcome the obstacles that were getting in the way of him being successful with his prescription. So that's where this picture came from, and it was just really, it grabbed my attention. And it was also something that he experienced out in the community. He felt very self-conscious about going outside because he felt like he would be stared at because he was so skinny. So I documented his journey as we worked on his recovery from malnutrition. So that's sort of the background of his story. So before the interventions that I did with him, which isn't really the point of this this part of the story. But before the intervention, he was not gaining weight, he was malnourished, and he needed extra calories, but he was maxed out on his protein. He was taking in 6 cartons a day of a 2-cal formula, and it still wasn't enough for him to gain weight. Like, he defied all of my math, right? He was just one of those people that has a high rev, and they're out there, right? They burn more calories than we think. So we were talking about some different strategies, and he really wanted to blend some formula and add it to his regimen, which I was fine with. And I cooperated with him and had him send me his recipe, and I altered it and pulled out all the protein and added some little more fat calories where it was needed. And that's how we collaborated to meet several needs. This was something he wanted to do because he had a history of cooking. He loved to cook, and he had lost that passion because it was, feeding and watering is just a very mechanical experience for some of these folks after they're reliant on a tube. And so this was something he wanted to do. He had a history of being a chef as well, so that was helpful, but that's what we did. And so our protocol was he would do 10 cubes a day. He would do blends, and then he would freeze them and in ice cube trays, and then we added 10 cubes a day to his 6 cartons of 2-calorie formula. And it finally tipped him over. It was like just what he needed, but it was more than the calories. He was taking agency in his nutrition support, and he was participating in a way that he didn't really have the chance to before. And it was something that I learned just, kind of working with him to meet his needs nutritionally, but there was a psychosocial aspect to this as well that was pretty compelling. So gained weight, and this is what his journey looked like. And this was something I published a while ago. It was really more of a story about recovery from malnutrition, but the bigger takeaway for me was, and how he touched me, was how simple it can be to kind of engage patients in their tube feeding journey in that way. So that was John. Okay, so let's change gears here a little bit. We'll talk about different administration methods and kind of options as it relates to tubes and syringes and bags and things of that nature. So let's start with French size of tubes. And I put this in here because I think it gives you a really nice visual if you're not ronding around the globe with tubes like I do. It gives you a real visual of what the different French sizes look like. So here's your 16 French, 18, 20, 22, 24. So I think that if you're involved in your patient's journey to a tube placement, which it sounds like maybe many of you are, you're getting some education on that, you can have some say. Like, if you know that your patient is going to want to add a thicker formula or maybe some blends, then maybe advocate for a little bit larger tube. You don't want to max out on the biggest tube possible, but maybe a 20 or 22 French instead of a 14 or 16 French. And you can see why just by looking at these tubes. It can make an impact on that patient's experience with their tube feeding. Okay, so let's talk about syringe feeding or bolus feeding. So this is helpful information, just knowing that there are different syringe options out there. This is a 60 ml syringe, and this is your standard stopper style syringe. And this is what's called an O-ring syringe. And this is something you can request in your order set to a home care company, is request an O-ring syringe. And the benefit to using an O-ring syringe, if you're pushing formula through there, or if you have any dexterity issues, which we know this population and their caregivers sometimes can struggle with navigating use of a syringe, that O-ring syringe has less friction. It's easier to use. So if you've ever manipulated a brand new out of the package stopper style syringe, these are kind of sticky and sometimes they're hard to manipulate, but using that O-ring syringe can make it a lot easier just from the lack of friction there, of resistance as they're administering water, medication, and feeding. Gravity bags. So this is something else not everybody is aware, but you can request small bore or large bore gravity bags. So if your patient is wanting to do feeds faster or is going to administer a thicker formula or a thicker blend, like if putting a 2-cal formula in this guy right here with no additional water, it could take a really long time for that gravity bag to drain. So if you're using a 2-cal formula, even a 1.5 formula, you really should be asking for a large bore. It's just called a large bore gravity bag. And it gives the patient, still has the option with this roller clamp to slow down or speed up the feeds, but this can make a big difference in the experience of tube feeding. So I wanted to pass that along. Then there's some innovation. If you are using one of the formula containers that's compatible with the Bolink D-cap, you can connect a patient's formula carton directly to this link. It's called the Bolink D-cap, and it connects directly to the carton of formula. And then this end right here is ENFit, and that connects directly to the patient's feeding tube. And they can actually bolus feed, or you can hold it to gravity directly from the carton of formula. So you're not dealing with pouring into syringes or drawing up, or even dealing with a syringe at all. This is what I would call an innovation. It's new. I mean, it's been available out there for at least a year or more, but it may or may not be available through that patient's home care company. So that's something that you would want to ask about. From an insurance perspective, it's coded as gravity. It does not require any special justification for Medicare. It does have that ENFit connector. So if your patient still has a legacy tube, they would need a little adapter, but it's a great option. So it's coded as gravity. Clinically, it's closer probably to bolus, but it's a really nice option that I think is a game changer in the way that we think about tube feeding. So I wanted to share that with you. And here's the link to, I guess these are snapshots from a little video education that I put together on this subject. And then made by the same company, this is called the Bully bag. So you can put commercial formula in there, you can put home blends in there, you can put standard or blended formula in here. And this is a really nice option for people who have, again, dexterity issues, don't want to deal with gravity bags. You can actually let the formula hang through this, which connects directly to the patient's tube with this large cap link. And it's a nice clean system. So again, coded for gravity, can feed similar to gravity or bolus, depending on how fast it goes through. They are, again, do not require any special justification. And then lastly, from the same company, this is a device that's called the Bolink small cap. And this one I think is really cool. I think it's a game changer too in the way that we think about tube feeding. So this is the device right here. It's just this short little small cap that connects directly to a patient's feeding tube via the ENFit connection. And then this is like a spike set. So it's the same design as a spike set into a ready to feed bag, and it can connect into pureed vegetables and fruit. So I have a patient that uses this for his prune regimen. He does prunes in the morning, prunes at night, and he just uses this little device to connect straight to it and doesn't have to deal with a syringe or anything like that. So again, a game changer, available as gravity coated, does not require special justification. Okay, so we're going to change gears again. Now let's move into tolerance and the way that we assess tolerance. I'm going to add a tolerance assessment of tube-related assessment here in a minute, but let's start with digestive tolerance, which we're all very familiar with, right? So we're asking our patients, are you having any nausea, vomiting, diarrhea, constipation? So I organized all of these things into a couple separate pages, if you will, right? So let's talk about we'll talk about constipation in a minute. So we'll talk about all the others now. So when we assess for nausea, vomiting, and diarrhea, there's all of these things that we should be looking at as potential causes for that, right? So if a patient's malnourished, and their microvilli are atrophied and they're not absorbing the way that they could if they were better nourished, that's something to keep in mind. Maybe they're malabsorbing the larger proteins or intact nutrients, and maybe they need something broken down until we're able to re-nourish them. Something that I have found along the way in home care is that sometimes patients feed too fast. I call it power feeding. And sometimes that feeding rate or the method is not a good fit for the patient. So we have to negotiate with them and ask the questions. So when you're assessing for tolerance, get very specific about the way that you ask what the regimen looks like. So when you're syringe feeding, how long does it take you to finish a carton of formula? How long are you spreading that out over? What does that protocol look like for you at home? Paint me a picture of that. And sometimes that can give you a little insight into what could be contributing to intolerance. Caloric concentration can play a role. Sometimes patients tolerate a 2-cal formulation and sometimes they don't, but verify that they're not overfeeding or feeding too fast before you go changing formula right away. The volume can sometimes be too much for that patient. So I've had patients that try to, again, just get it over with because it's just a part of their day that they want to get over with because it's not something they can sit down and enjoy like they used to. So sometimes they'll put too much volume at one time, and sometimes spreading that out can improve tolerance. So instead of 2 cartons at a time, maybe we do 1 or 1.5 and then give it a break, or give a carton of formula over 20 minutes, wait an hour and do that second carton a little later, something like that, if they want to do 2 cartons at a time. There's GI tract function changes along their disease process, so that's something to keep in mind. And then gastroenteritis, so sometimes patients just get sick or they've got a temporary situation and they're not feeling well for a little while. So we have to think about that as, is it something that's going to endure? Or is this just a short-term event? They have a bug and it will pass, or it's actually a result of some severe intolerance of that formula. So moving to constipation, which has its own page here. We know that the issues listed on the white page can impact and contribute to constipation, right? So let's dive deeper. Fluid intake, we know, is an obstacle for some of our patients along the way, especially as their disease progression is sort of ramping up and they're eating less and less, they're taking in less and less fluids. It takes the highest amount of swallowing ability to actually swallow thin liquids like water. So we know that fluid intake can play a role in that. So making sure that their tube feeding regimen has adequate fluid is really key. And fiber content, we want to add fiber if it's not already in their regimen. So that's something that we know that dietary fiber improves laxation. Activity level, that's going to be very patient specific and what they are able to do, but we know that that contributes to constipation. And of course, pain medication plays a role in that as well. So I'm curious, and maybe we can talk about this later, what normal bowel function is from your perspective, right? It's a subjective assessment. So we need to define what regular bowel movements look like. Put in the chat, I'm curious, I'm going to test my practice, but put in the chat, if you will, like, what is your threshold for intervention, if you will, before you recommend an intervention for somebody who hasn't had a bowel movement? Like, what is the most amount of days that you are willing to tolerate in a patient not having a bowel movement before something is recommended? But while you do that, I'll talk about what is in the literature. 3 times a day to 3 times a week is considered normal. Absence of symptoms is important, like bloating, gas, having that gurgling noises or discomfort. And we know that quality of life suffers greatly when gut health is compromised. All right, let me go look at my chat here. Okay, it's starting to add up. 3 to 4 days at the Cleveland Clinic, 3 days assessing normal GI function, what's normal for the patient. Yeah, so Jacqueline, like what you guys are saying, that's what I've always felt, like 3 days is sort of my max tolerance as well. Baseline bowel habits and 1 to 2 days from that, 3 days max. Yeah, this is great. Okay, thank you all for sharing that. I'm checking my work. All righty. So I want to share this with you. Masmunder and colleagues looked at the burden of constipation on ALS patients and found that they, as you know, report higher rates of GI dysfunction, particularly constipation, but the extent of that and the severity and the relationship to the dysautonomia is not well understood. So this is showing you that this is what's called a PAC QOL, or a patient assessment of constipation. And I have a snapshot of the survey here. And so what this study did was they looked at their results on this PAC QOL, I'll call it. And they showed higher medians for physical discomfort, for psychosocial discomfort, for worries or concerns, right? They get, it just has this overall impact on quality of life and satisfaction when patients are experiencing constipation. So the takeaway in their study was really to individualize treatment for GI dysfunction because of the impact on quality of life. So as you know, there can be a discrepancy between clinician and patient reports of constipation. So our threshold's 3 days. A patient could report constipation because they didn't have a bowel movement, today, but they did yesterday, right? So maybe the patient's threshold is 1 day, but as clinicians, ours is closer to 3 days. So we really need to clarify that. So Samara and colleagues undertook a survey using formal questionnaires for symptoms of constipation administered to patients that were seen in their multidisciplinary ALS clinic, and this was done at the University of Utah. And the survey was administered at their second or later visit. And they also surveyed about treatment options and the efficacy of those, but I'll talk about that in a second on the next slide. So let's talk about the symptoms and what they found in their study. So there's 2 different cohorts. There was a pilot cohort that had 30 patients, and then they had a second cohort that had about almost 70 patients. So in each, before diagnosis of ALS and after diagnosis of ALS, the incidence of constipation increased. So I don't think that is a surprise to you. What I wanted to also share was their findings with this same group. They surveyed which interventions were most effective. So the top 4 were docusate, diet, fluids, and exercise, polyethylene glycol, and then fiber supplementation. So as you know, docusate, it's a stool softener. It works by increasing the amount of water that the stool absorbs in the gut, and that makes the stool softer and easier to pass. And usually relief is seen within 1 to 3 days with this medication, and it's known by the brand name Colace. Polyethylene glycol is in a class of medications called osmotic laxatives, and it works by causing water to be retained in the stool, and that increases the number of bowel movements and softens the stool so that it's easier to pass. And so this is a brand name, Miralax, as an example that you might be familiar with. But I wanted to share that with you from this study as well. And I'm curious to see what you use in practice and what you see as effective across all of these, whether it's a fiber supplement, a medication, formula, regimens. Interested in learning from you as well on that. So that concludes the digestive tolerance. Let's talk about tube-related tolerance. So we look at leakage, obstruction, displacement, or if that tube falls out or gets pulled out, and then stoma complications. These are the ways in which we assess tube-related tolerance. And so when you think about these things, talking to the patient about these sort of symptoms or taking a look at the feeding tube, and so I challenge you to do that if you're not already doing it, including it in your nutrition-focused physical exam, looking at that tube and seeing how healthy it is. Let's talk about leaky tube first. So this is probably one of the most common complaints I started experiencing when I worked in home care. And prevention of leaky tubes, first thing you need to do is figure out where is it leaking from, but prevention is just proper placement of the bolster, proper inflation of the balloon, proper sizing if it's a low profile device. But this is what leaking can look like. And so what I always had to figure out was, is the tube actually leaking at the stoma? Which these two are examples of that, but sometimes patients' tubes leak because the port cap pops open, right? So that's a different kind of fix than somebody who has a leaky tube actually at the stoma site. I've had patients that leaked at the stoma site because they were feeding too fast, too much, too fast. So I had to have them slow down, and that resolved it. In other cases, it's because the balloon is not inflated properly. So it's important to make sure that the balloon, if they're using a balloon style gastrostomy, is properly inflated. If it's underinflated, you could see where formula could leak out there. But these are key ways to address leaky tubes. Clogged tube, it's important to prevent it first and foremost. So I recommend what I call a water sandwich. So using water before and after anything that comes through the tube. So before and after medication, any prunes, any formula, right? Anything that goes through that tube, you use a water sandwich and sort of add that into their daily water intake. If you do have a clogged tube, then I recommend using a smaller syringe. If that large syringe with that rocking technique does not work, using a smaller syringe, like a 6 or a 10 ml syringe in the med port, can help dislodge that clog. You don't want to use anything smaller than that because the force is so much higher. You can't actually damage the tube, but a 6 to 10 ml syringe can help unclog a tube. Prevention is key, so making sure that anybody who's using a blend is using a high quality blender or blending longer. So that will help with success is increasing the blending time if they're using whole food. So tube displacement is, so that's when the tube falls out, if a balloon ruptures, so making sure that patients know what to do in that situation. They have a backup tube on hand and they actually know how to replace it. That is an option, but most of the time in our adult population, patients are advised to go into the ER, and that's generally what happens to get that tube put back in and to verify its placement before it gets used again. And that stoma can close up within 2 hours of that tube falling out. So just make sure that patients are aware they need to work on that as quick as possible. And so verification of tube placement is key. That's what's happening here, is to make sure that that tube is all the way on the inside, especially if it's a higher risk situation if that tube is new. If the stoma's been there and matured for 6 weeks or longer, then there's less likely of an issue of peritonitis. But it's really important to make sure that that tube placement is confirmed and that the balloon is all the way through the stoma and not stuck somewhere in here. So stoma complications, so I'm going to go through these quickly because I could spend an hour talking about this, but I want to convey to you the essentials and leave it as a reference for you. Hypergranulation is the most common complication I see at stoma sites. It's one of those things that a lot of clinicians out there will tell patients, it's normal, you don't need to do anything about it. But I have a problem with that because it isn't normal and you do need to do something about it. So if a patient has this hypergranulation, which is proud flesh, it's hypertrophy, it's cells that are growing abnormally at the stoma, at the actual site of the stoma, often because that tube is moving around too much, or in this case, this tube is actually too big for the stoma, so there's too much movement and it causes hypergranulation. It's important to adjust that tube or resize it to make sure it's fitting properly so you can avoid this. But there are treatments that can be done for hypergranulation, and my recommendation is using an over-the-counter home care friendly technique with hydrocortisone cream, BID, right on that stoma site, nowhere else, just on the stoma site for a couple of weeks, and then reassess. You can actually beat down that hypergranulation and so that it doesn't cause other problems. Hypergranulation is one of those things that's not comfortable for the patient, doesn't feel good to have it. And it creates this kind of ooey gooey mess. And some people think that there's a bacterial infection at the stoma site when really it's just hypergranulation creating this ooey gooey mess. And that actually can be addressed. In resistant cases, severe cases, silver nitrate can be used, but it's not my favorite. It hurts and it burns. And many times I can have better results just with some patience and some hydrocortisone cream application at home. Yeast infection is probably the second most common complication I see, the tube site. So that happens when there's too much moisture, and there's too much moisture because there's a leaky tube potentially. If the tube is leaking because that bolster is set back too far, then you need to get to the root cause of the moist area and make sure that tube is fitting properly so that it's not leaking, making sure that balloon is inflated properly so that it's not leaking. But you want to protect the skin with barrier cream. Nystatin is a great over-the-counter option for patients. It's easy to get, but using an antifungal topically for twice a day for a couple of weeks can help, and then reassessing can help beat down that fungal infection, and then the hydrocortisone cream can actually help resolve the erythema. And so yeast infections hurt, they burn, and it impacts the patient's relationship with their tube and their experience on tube feeding. So yeast infections need to be prevented at all costs and addressed quickly when they do get identified. And then the least common thing I see is bacterial infection. So this is a really severe one. For instance, this is a J tube. Ironically, it's a Foley catheter, or Red Robin catheter. I recognize that being used as a feeding tube. But what happened here is this patient got cellulitis and they needed a systemic antibiotic. But if you've got just a little local infection at the stoma site, using a prescription antibiotic cream on top of that tube versus a systemic could be a better option so that you don't wipe out the entire, microbiome with antibiotics. So if it's a smaller infection and you can handle it topically, that's really a good way to go. So in summary, what I hope you come away with knowing is that clinician knowledge of enteral formula innovations and these supply innovations and different options for patients in the home setting is imperative. And the use of whole food formulas, they're doing it. So ask about it, but it doesn't need to be an all or nothing proposition. There are ways to weave it in for patients and meet certain clinical needs and tolerance needs. And then troubleshooting and monitoring should include not only formula tolerance or that method of administration tolerance and GI tolerance, but also access device tolerance. And I think that that's something that sometimes doesn't feel like it's in your scope as a dietitian, but I'm here to tell you that if you're dealing with patients with feeding tubes, it is in fact in your scope. So that concludes my presentation. There are references here listed for you, but I wanted to save some time. I think I did pretty good here. We've got a little bit of time for Q&A. So let me hand it back to you, Steph.